My name is James Deering. I'm a principal investigator for a study funded by the Robert Wood Johnson Foundation. What's so special in our particular project is that we were studying innovations from other countries, especially developing countries, that then are exported to the United States in the hope that they might benefit U.S. communities.
We had a list of 40 innovations initially.
There has been research conducted for about 100 years in what explains the spread and the effectiveness of innovations in health and healthcare, but there has not been much attention at all on identifying very promising answers to improving healthcare and improving health from other countries and then importing those into the United States.
Together, our team worked to build a conceptual model that would explain why certain ideas move from the global or international context into the U.S. context and what the elements are that predict that movement.
It's like developing a pathway, even though it's a conceptual one, that other sorts of stakeholders, other foundations, other university researchers could follow, as well as community leaders, if they want to import a health innovation from a developing country. We selected these 5 innovations because each had evidence that they were effective in either improving healthcare or improving health.
It is so popular, it's like a policy.
The first of these innovations is something called Ciclovia, which is an open streets initiative here in the U.S. And what is done in those open streets initiatives is they close down streets in a city and people ride their bikes, they walk, they experience the community. Our second innovation is called Age Well. It was originally started in South Africa as something called Mother to Mother. And at that time, it was all about a peer-led, peer-to-peer intervention to help reduce mothers' risk for HIV transmission. As it evolved and came to the United States, it retained this peer-to-peer concept, and it was focused on having elderly people help other elderly people maintain healthy lifestyles. Our third innovation is what's called the Cardiff Violence Prevention Model. And this is an innovation that's about violence prevention. It was developed based on the idea that police departments don't have all the data about violent crimes, but when you put police data together with emergency room visits and you look at that complete picture, you can see more about exactly what that crime looks like, and you can map where violent events are taking place so that communities can identify appropriate interventions for reducing violence in their communities. Our fourth innovation is called Consejo Sano, and this is really about bringing healthcare services to Spanish-speaking people within the United States who don't have access to care necessarily otherwise. Our fifth innovation is the Swedish Patient Registry. It's basically a data integration where patients and providers, nurses, doctors, social workers, all are able to access a common database that can track a patient's health and health outcomes in a way that really hasn't been seen before. In certain cases, we know that an innovation, it could start anywhere in the world and move into the U.S. context and take off. Part of our study is to figure out why and when this happens and when it doesn't happen. And we're most interested in what are the facilitating conditions within the market to help something grow? What are the things within a market that stops things from growing? So if you take something that's trying to move into the U.S. healthcare system, for instance, our healthcare system is very complicated. There are many rules about how information can be shared across providers, between the patient and the provider, et cetera. So that's an example of a piece of the healthcare system that might be restrictive if you have, for example, innovations that are designed to share information across groups.
In our conceptual model, a linking agent is an individual who plays a special role, and this is frequently the innovator, let's say a woman in South Africa who creates a new way of providing healthcare to individuals, and she becomes the face of that health innovation. So we wanted to know, what role did linking agents play, if any?
The other thing that's coming out pretty regularly is that partnerships so far have really been the key to getting these innovations off the ground in the communities where they've started. Part of what we're trying to understand is what are the partnerships that are built? Who are the people, who are the individuals or the organizations that help something new come into a community and to grow within that community? They often start out with local community level partnerships. So if you take the Cardiff violence prevention model, the way that that gets implemented is by partnering hospitals with police departments, for example, to do data sharing.
In this particular model, the innovation through a linking agent was brought to the city of Milwaukee, Wisconsin. And the partnership formed both locally, involving the medical college as well as the local police department, and also the emergency room of a local hospital. The linking agent and a partnership for a health innovation interact in a very interesting way based on our results. The linking agent gets the innovation into a new community. The partnership makes the innovation run in the new community.
Scaling up means allowing an innovation to flourish within a new community or a new place. Scaling up happens when you've got linking agents who have made that initial connection in order to allow an innovation to take root in the United States. You also oftentimes have partnerships that then can help grow the innovation. The big picture right now is we've got this model. We want to see whether our model explains this diffusion process. And then the next step is can we create an automated decision tool that allows somebody to make a better decision about what innovations they move into the US context in order to identify things that are likely to spread.
One of the key findings from our study, and it was a surprising finding for us, is that we expected stakeholders in US communities might have negative reactions to health innovations coming from developing nations. So we were surprised when this was not shown through our interviews and through our document collection and from the site visits that we did.
For the innovation.
Adaptation matters. If the local stakeholders are able to change certain things, to rename the health innovation, to add components to the health innovation, if they're able to do things, in effect, to customize it to their local community, that innovation stands a better chance of both diffusing to more localities and of scaling up in those localities where it's implemented. These 6 factors and their variables were going to be important.
Our findings also show that the context in which an innovation moves into the US, and so this is like the cultural, political, and social context of the US system, has an impact on the idea to bring that innovation to the US or to try to bring that innovation to the US, and then ultimately to whether or not that innovation is successful within the US system.
My team has been fascinated with this study because of the possibility of making a contribution for improving healthcare in the United States and improving the delivery of health in US communities.
This research team and working with them has helped me learn a lot on different things that can be done to improve the quality of life of people.
When you can use an idea in practice and try to resolve a problem, everybody will be happy, healthier, safer, and that's the intention with the project.
We're living in a time where health quality is low and health costs are high. It is quite important to get innovations that can drive these costs low and improve quality of health. It's really my passion.